Thank you very much, and thank you all for the invitation. I'm going to follow on from Dr. Goodman's excellent talk by agreeing with what a lot of he said. And one of the messages that I want to come across in this short talk is that you're dealing with POTS, which is common, but you're also probably dealing with antiphospholipid syndrome, maybe associated with Sjögren's, much more than we realized. So, my first slide. A few years ago, we wrote a paper with a couple of colleagues. Jill Schofield, who's in Denver, came over to my unit in London, and in no time at all collected a series of patients with POTS and other autonomic disorders in the antiphospholipid syndrome. And I was a newcomer to the detailed studies of POTS that all of you have been hearing about in the previous talk. So in this 40 minutes, I'm going to give you a history of where we were and where we are now up to in dealing with the antiphospholipid syndrome. I was given the title that Hughes syndrome and antiphospholipid and dysautonomia, there is a new clue, and it's quite a strong clue that is now coming out. Do you suffer from migraines? Do you get cold hands? Well, there may be a feature of POTS, but they're a very, very major feature of the antiphospholipid syndrome. In fact, I would say migraine headaches, which I'll come back to, are one of the major features of this disease. And I would put it this way: Doctor, do you have any patients with migraine headaches or suspicion in the past of a clot or a deep vein thrombosis? Recurrent miscarriage? 12, 15 miscarriages in some of our patients. Memory loss, maybe the number one feature of the disease. And the worry of strokes, real strokes and mini strokes, transient ischemic attacks. These are the features in the antiphospholipid syndrome, which has also been called Hughes syndrome, and in Japan it's called Dr. Hughes syndrome, which I'm very proud of. We call it sticky blood. The media call it sticky blood, which is factually not quite correct, but it's a good way to think about it. The pathology here, we believe, is a sludging of the blood, which affects all organs, but notably the brain. This is a neurologic disease with other features thrown in. The main pointers, just to summarize the talk at the beginning, are teenage migraine, tendency to thrombosis, strokes and memory loss, recurrent miscarriage, including, tragically, a late miscarriage, stillbirth, and cold, blotchy circulation, including livido reticularis. What about the tests? Well, I wasn't going to go into detail, but there is a simple blood test, which fortunately are moderately helpful, and they are tests for anticardiolipin, the dreadful test called the lupus anticoagulant, which is a mishmash of clumping red cells, and it depends on the phase of the moon. There's a third test called anti-beta 2, but I'm not going to bore you with that. Suffice to say that, as in the lecture you've just heard, the tests may all be negative, and the patient then gets a very hard time from the doctors who don't perhaps believe her. Let me go into the history. You've just heard a little bit about our history. My own training in London was interrupted very happily by 2 years in New York with Dr. Charles Christian, first in Columbia Presbyterian and then downtown. And really, he was a great leader and one of the world authorities on lupus, which is where I got my interest, returned to London and set up the lupus clinic there. And 35 years ago, we published a number of papers. We published the Heberden Round. Now, in those days, in the British Society of Rheumatology, we had an annual meeting, and in it we had a ward round, so-called, called the Heberden Round. And in those days, patients used to come to this meeting and discuss question and answers with the doctors in the meeting. And in this meeting, these are all patients with lupus, with various forms. The lady in the wheelchair with shrinking lungs and elevation of the diaphragm. The lady on the right was found wandering around London emptying garbage cans with psychosis, and she's now completely well. But amongst these patients were 3 with what we thought was a new subset of lupus, the sticky blood syndrome, or antiphospholipid, as we now call it. The third lady from the right, as you can see, is quite swollen because of steroids. Was thought to have lupus nephritis. She didn't. She had clots in her renal vessels, renal vein thrombosis, and had features of antiphospholipid syndrome. So in 1983, we published our first papers on the syndrome. And the one in the British Medical Journal we called Thrombosis, Abortion, Cerebral Disease, which I will come back to, and that test called the lupus anticoagulant. We also set up an assay for anticardiolipin antibodies, and this was published finally after about 1.5 years of going round in circles, as many of the doctors will know. It was published, anticardiolipin antibodies, and one of my junior fellows, Nigel Harris, was the first author. Nigel, many of you may know, came to work in Kentucky. This was for us very exciting because in the world of research, there's a lot of drudge work, but once in a while you get an observation that you know is important. And we were so excited by this publication. This was a cafe, an Italian pizza place where we all went to celebrate on the 26th of November when this was published. And these were our team then at my old hospital, the Hammersmith Hospital. All people involved in those clinical studies back in the early 80s. A year later, we published a world symposium. Now, this was very grand of us, very big-headed. I think we had 47 applicants who joined us at this world symposium. And since then, it's gone from strength to strength. There's a world symposium now every 2 years. There's local symposia in every European, certainly, country every year. And these are some of the people who've been involved in that research. Nigel Harris up at the top left, Dr. Kamashta, my colleague, in the middle, Silvia Pierangeli, who sadly has died, up in the top right, and at the bottom, Silvia Tincani from Italy. Been a very international group and been a very collaborative disease to study, I must say. Well, over the next 20 years, there have been huge interest and new findings. The biggest success has been in pregnancy, and this has been the headline. Once upon a time, women with positive antiphospholipid tests had under 20% success rate in pregnancy. Now, in all international clinics looking at this disease, we're talking about over 90%. It is now the commonest treatable cause of idiopathic recurrent miscarriage. So it really has been huge in the world of obstetrics. Now, I was talking to one of you just now in the coffee break, and the same old story. She was told she must have more than 2 miscarriages to have the disease. What rubbish. It's a committee decision. It's one of those things that's costly to test everyone, but it's not. It's the matter of a blood test to stop the tragedy of early or late or recurrent miscarriages. What's very interesting over the last 20 years is how common this disease is. And this highlights the 1 in 5 study, which is very crude, but these are all publications. And about 1 in 5 patients with recurrent, 3 or more recurrent miscarriages are APL positive. 1 in 5 of all DVTs positive. But here's the big one. 1 in 5 of young strokes, women under 40 with a stroke, 1 in 5. Now, the British government has got a big financial thing at the moment to highlight stroke. But guess what? There's no mention of the antiphospholipid syndrome as something that could be tested for. Very slowly, the cardiology world has got very heavily involved in the ischemia story. And we now know that 1 in 5 women under 40 having a heart attack have got sticky blood, something that is preventable and treatable. More recently, and I'm just going to mention that, epilepsy has become a story of the last few years. So the media are getting to know about it. This was a visit we had from Diana, the Princess of Wales, who had a friend with lupus and was fantastic, sat on the bed of every patient in the ward, and really did quite a lot behind the scenes for patients with lupus and with antiphospholipid syndrome. So in the next few slides, I'm going to talk about individual patients in a very clinical manner. And I'm going to call it the view from our clinic. This is our clinic with a little arrow on it, very nicely placed on the Thames next to Tower Bridge and between London Bridge and Tower Bridge. And I'm going to talk about a few doctors' letters. I'm not going to talk about 5 just for time's sake, but a couple of things that we regularly hear from doctors. Number 1, diagnosis. Dear Dr. Hughes, re Mrs. Smith, although I suspect APS, she's never had a thrombosis or a miscarriage. Well, I think that's such a lesson. We know that antiphospholipid syndrome is not just thrombosis and miscarriage. Yes, it is. There's newspaper articles about tragedies such as the girl having 2 strokes and so on, and the stories of miscarriages. But let me start with teenage migraine. This is such a common feature of this syndrome. And obviously in those with POTS, it's going to be difficult to sort out A from B. Quite characteristically, these patients start in their teens with headaches, migraine type, very frequent. It's often in the family, funnily enough. It sometimes goes away and comes back in the 30s or 40s. Doctor, I was fine for 10 years, but the headaches have come back. And very, very interestingly, it can respond very dramatically if you thin the blood. Anticoagulation, for instance, with aspirin. And this is something that we have learnt in the lupus pregnancy clinic. Some of those women 9 months on heparin, for instance, have not a single headache during the 9 months. Now, all neurological features, as you heard in the previous talk, can occur. A number of our patients in the early studies, we looked at myelopathy. We looked at a disease called Jamaican neuropathy, which is a virus, a paralysis, a paraplegia, and we found that they had false positive tests for syphilis. And the reason for that is their antibodies were against a thing called phospholipid. And our theory was that these antibodies were directed against brain neuronal phospholipids. That probably wasn't correct, but what we did find was these patients had all the features of what we now call Hughes syndrome. Some of our patients have come to us with a wrong diagnosis or a possible diagnosis of multiple sclerosis. This is one of the most difficult aspects of all our clinics, and certainly there are those patients who have turned the corner when the real diagnosis has been found. But in our neurology clinic, it is proving very hard to differentiate true MS, if you like, from the antiphospholipid syndrome. What about memory loss? This is really the common one. If the patient is not treated and has antiphospholipid syndrome, memory is the problem. I really can't find the words. I'm the joke of the family. One of my patients, for instance, couldn't find the way to school when she exited from the traffic circle. And these frightening memory lapses are a feature of the disease. One of our patients was the darts champion of her village, and suddenly she couldn't remember where the 20 was, very focal neurological defect. And this is really a major, major feature of the disease. Many of our patients worry that they've got Alzheimer's. And it's quite interesting. This letter, dear Mrs. Jones, despite being on warfarin because she's had a clot, her memory loss, headaches, and balance problems have not improved. What's this patient teaching us? Well, this cartoon shows that we see many, many of our patients who've had severe problems, neurologic or clotting, are on anticoagulation, for instance, with Coumadin, warfarin. And when they measure their INR, which, as you know, is the measurement of blood thickness, they know if the INR falls. If the blood gets too sticky, back come the headaches, back come the balance problems, back come the memory problems. And I've got one wonderful lady who does the Times crossword every day of her life. in about half an hour. And she started to take an hour and a half. And to cut a long story short, she had antiphospholipid syndrome. She got a clot, was treated with warfarin, and back came her memory, back to the Times crossword in half an hour. And she runs her own INR self-testing machine, which is my religion. The patient takes control of their treatment. And she's doing a graph for me now of time of her INR and the time to take the Times crossword. So I'm going to publish this one day. Now, the next feature, and again another neurologic feature of the syndrome, is epilepsy. Epilepsy, since the very beginning of our discovery of this syndrome, has been a feature. Teenage seizures, for instance. But it's been updated enormously. In 2002, Ronaldo Simas, who was in Italy then, published a paper showing that in idiopathic childhood epilepsy, over a quarter, 28%, had positive antibodies. A huge story if it's true. These are teenagers who've not had accidents or brain damage of any sort. And they've updated this in more recent studies. Epilepsy is a part of SLE and systemic antiphospholipid syndrome. And this, again, comes from the same group, Simas, Meroni, and Yehuda Schoenfeld. And if you want an up-to-date review, there's an excellent one in the journal Lupus by a group led by Neuraldine, and it is Hughes syndrome and epilepsy. When do you test for antiphospholipid antibodies? And the interesting finding was, if you have individuals with positive antiphospholipid tests, they were found to be 11 times more likely to have seizures than patients negative for these antibodies. This is a fascinating patient. This is the wife of a diplomat, and it was posted to London and came to see me. She came from Boston. She's the wife of obviously a high-ranking American diplomat, age 41. And she had, you won't know better than I do, that's Boston. She had a history of mild lupus, treated in Boston with Plaquenil. She's weakly positive anti-DNA antibodies, but they found her ACL very, very high units. Her main problem was not lupus, but was epilepsy. She was on no less than 6 anti-epileptic drugs. And fate took a major hand. Within a week of maybe it was the plane journey, but within a week of getting to London, she had a DVT. She was treated with heparin and warfarin, and maybe you've guessed it, dramatic improvement in the epilepsy, now on 1 anti-epileptic drug alone. Now, this is a case history, anecdotal, but it's certainly a story that we are seeing more of with our neurology colleagues. What about other organs other than the brain? Well, the skin, I think you've heard in the last talk about skin involvement. Some of our patients, some of our worst patients, have livido reticularis, this blotchy feature on the skin. One of my patients calls it corned beef skin. And it comes out in the cold. It can be normal, but it's very much a feature of sticky blood. Abdominal pain. Many possible causes, as you've heard in the previous lecture. But one interesting cause is this, narrowing of the artery. For instance, we had 57 cases we published 10 years ago of celiac artery stenosis. Maybe you can see the top little arrow showing quite a localized stenosis. And what we believe here has happened is a clotting which has opened through partially. And these patients, not all of them, about half, suffer from abdominal angina. In other words, a big meal, abdominal pain an hour later. And we now have a series with renal artery stenosis, carotid artery stenosis. It does seem to be a recognized feature. What about rheumatology in the bones and the joints? Well, here's an interesting one, which really we stumbled across, and that was spontaneous fractures. Dr. Siri Sangl, who was a research fellow in our department, collected 29 patients with antiphospholipid syndrome who had spontaneous metatarsal fractures, shown by the little arrows here. Many people, as you know, call it march fractures. And it's because soldiers on their first long march sometimes got idiopathic fractures of the metatarsal. But we've seen it now in other places, tendency to fracture in antiphospholipid syndrome, presumably because of ischemia to the bone, but not quite certain. It may be a major feature. Dr. Kamashta, my colleague, anecdotally reported a patient aged 59 who had 52 bone fractures. This was not osteomalacia, porosis, or anything. It was in a patient with severe APS. And just to finish the picture, you can get bone ischemia, lack of oxygen to the bone. And one of the places that does not like ischemia is the hips. This MRI shows both hips, at the top of which is an area of darkness and softening, which we call avascular necrosis. And hip pain is not an uncommon complaint in our patients. Now, the x-rays may be normal, but if for any reason they get an MRI, it does sometimes show idiopathic avascular necrosis. Many of you may know that this is a feature we see of lack of oxygen in the hip, for instance, deep-sea divers or patients with very high cholesterol. But I think this is a condition that also can cause this. And finally, cardiovascular. For many years, we know that the valve of the heart can get clotting. This used to be called Libman-Sachs endocarditis, was known in lupus, but mostly we believe it's associated with the antiphospholipid syndrome. And these clots can not only stick to the heart and throw themselves off and cause strokes, etc., but they can damage the valve. And very occasionally, in my experience, once or twice a year, we see a patient who's had to have valve surgery for mitral incompetence, for instance. But bigger than valve disease is coming back to coronary disease. There's quite a few papers now out on angina in our patients with APS, sticky blood involving the heart. This was a paper by Greco and colleagues from the States. We looked at 344 acute coronary patients and found a positive antiphospholipid in 40%. Another paper from South America, myocardial ischemia and SLE patients, a common but silent abnormality. And perhaps most commonly recognized, the pregnancy problem. Dear Dr. Hughes, re Mrs. Smith. Mrs. Smith has had a stillbirth. Could APS be a risk factor? Well, certainly it could. Most people have concentrated in the literature on miscarriages, but very sadly, late pregnancy loss can occur, and is a Times article classed it as one of the biggest tragedies known to mankind. There are now data suggesting it is associated. The group here in the States, in Salt Lake City, have published data showing there's a definite association with sticky blood. So a question which I've been asked here in this room is, when do you test in pregnancy for antiphospholipid? Do you test all pregnancies? I mean, the test itself costs, what, $10? It probably costs $50 really, but it's actually what it costs is about $10. Should you test everyone? Well, sadly, the committee that looks at these things decided cost effectiveness was probably you need 3 miscarriages or more before you get tested, which I think is scandalously wrong. The stillbirth scandal, every day as many as 3 babies are born who could have lived. And it's time for the National Health Service to adopt new policies and a new attitude to avoid this tragic problem. I point you to one paper. It's by Rob Silver and in Ware Branch's unit, and this is quite an old paper, 5 years old, showing that there was definitely an at-risk of stillbirth. And my suggestion is this. When a woman comes in to the pregnancy unit and is questioned by the doctor or the midwife, they should be asked 3 simple questions. Have you had a thrombosis? Are you a migraine sufferer? And most important, do you have a family history of autoimmune disease, such as lupus, rheumatoid, MS, or thyroid disease? And I think that would and we know it would, select out the subgroup most at risk. And my final doctor's letter is the heart sink patient. And this is, I hate to say it, but this is an absolutely true letter received 25 years ago. Dear Dr. Hughes, I'm delighted to tell you that you have won Mrs. Shuttleworth in our hospital draw. Wouldn't be allowed now, but this is the drawing that came with this particular patient. This is her symptoms: fainting, low blood pressure, poor memory, dry mouth, palpitations, hip pain, tingling, cold feet, knee pain, tummy pain, short of breath, blurred vision. And you all know it is, in her case, a combination of Sjögren's and POTS. And she, in fact, became one of the series which Jill Cofield collected now 3 years ago. We found 14 patients with POTS who had classical antiphospholipid syndrome. It's still a small study, but the common sense is there that this is one of the autoimmune diseases, such as Sjögren's, which should be added to the autonomic problems that you're talking about in this meeting. Has this got any relevance to the disease? I think it does. And here's one single email from a patient with antiphospholipid syndrome and POTS. Within 48 hours of starting heparin, which I will mention, headaches gone, tinnitus gone, stomach pains gone, numbness, heart palpitations gone, balance better, brain fog 50% improved. And none of these had responded previously to the normal POTS medicines. So I think the clinical ripples are spreading. I certainly agree with the last speaker that the autoimmune features are strong in POTS. We see a lot of Sjögren's. It's one of our primary diagnoses. And I have a thing called the big three in our clinic. 3 conditions which go together hand in glove. They are Sjögren's, Hughes syndrome, and hypothyroid syndrome, or Hashimoto's. And all 3 cause a variety of things, including dry mouth, migraines, etc. But what all 3 do cause is fatigue. And the doctor treating just one, say Plaquenil for Sjögren's, sees that the patient's not improving fully because he or she is missing the other 2 conditions. And I think it's a very important thing for us as doctors to learn that it's not just a single thing to treat. Maybe there are other associated diseases. Well, I was asked at a meeting not so long ago, could I predict things for 2050? Well, here for what it's worth are my predictions. I predict that antiphospholipid testing will become worldwide. There are improvements right now in testing. In our lab, that's our main work, is looking at the seronegative bunch of people, those with classical Hughes syndrome, whose tests are negative. I've got a pair of identical twins, both with Hughes syndrome, one antiphospholipid positive, one negative, and it happens. But there are movements of success coming. There's new tests slowly coming in. The second one is, I think that there will be over-the-counter kits available. I'm one of those people who believe in this. I think it should be available for intelligent families to get together and say, I'm going to buy that and test. The third is, I think there's a new hope now for some migraine sufferers. We still don't know, for instance, if you run a migraine clinic, what percentage have some of these known autoimmune associations. And certainly my own feeling, and this is a prediction, is that antiphospholipid syndrome may be one of the known links between migraine and stroke, that there is a literature about this. I mentioned the stillbirth scandal. I think that with our knowledge of this association, stillbirths can be cut, and I've guessed it, by 50%. Young heart attacks can be reduced. The cardiology clinics looking at angina in 40-year-olds or under will surely be adding this to the cholesterol and other tests which are done. And last, memory loss. And some cases of memory loss are not Alzheimer's. And this is one of the causes which are treatable of memory loss. Some cases are treatable. And last of all, in the disease which I certainly deal with mostly, in lupus, there is success. Fewer cases of being over-treatment. This girl on the left came to us from Romania in Eastern Europe, grossly Cushingoid on steroids. She had migraine headaches, she had memory problems and balance problems and some personality problems, and was diagnosed as cerebral lupus, which in those days was a knee-jerk diagnosis to give high-dose steroids. Well, she didn't. She had antiphospholipid syndrome, and this is her normal girl now on lifelong Coumadin, but living a perfectly normal life. It has changed our concept of lupus. Maybe 1/3, maybe 1/5 have got the antiphospholipid syndrome associated. And we need new ways of thinking that it should not just be immunosuppressives, but in these cases, treatment to help circulation. So the antiphospholipid syndrome, which I hope I've summarized here, touches on all branches of medicine: psychiatry, I've mentioned, obstetrics, neurology, transplant surgeon. Transplant surgeons now are always testing for antiphospholipid, because why have a transplant that's successful and then to lose it with a thrombosis? Gastro, hypertension, orthopedics, and so on. And certainly in the world of POTS, I think this is a new clue, and I'm sure that we will be taking this on board in short time. So to us here, doctors and patients alike, there are challenges. Antiphospholipid syndrome is relatively new syndrome, it's 35 years old. Lupus is older, but not that old, 100 years old or whatever. But the big challenge, I think, is that we are teachers. Everyone in this room knows a little bit more about POTS and about antiphospholipid syndrome that the world outside does. And I think it's our duty to teach and to pass those messages on. And this goes back to 1983 in the BMJ paper. For those of us hardened into nihilism by years of study of various autoantibodies in SLE, there's a rare sense of excitement at the implications of the associations now being reported. Thank you very much. Yes, happy to do any questions if that's... Okay. There's a hand at the back. Can you? I didn't hear it. I'm really not hearing you. I'm so sorry. No, I do have an opinion. It's not been of very great value to us in our management, I'm afraid. It's been disappointment.
What's the reasoning to do repeat APS testing?
Well, it's something I really disagree with. And we are told that to diagnose or to classify APS, you have to have 2 positives 12 weeks apart. And this is for the reason that very occasionally an infection, an acute infection, can cause a weak positive antiphospholipid test. So the committee that decided all this is like the ACR lupus criteria. They're for classification, not diagnosis. And it's been a tragedy because patients, in some countries, can't afford to come back for 12 weeks for a second test, and you're wasting time. I think if you're sure of the diagnosis, you treat the patient. But it's stuck, and certainly in the UK, doctors say, well, she can't have the disease because she's hasn't had the second test. One more?
Thank you. If you have a patient with a suspicious history and one positive test, or even no positive test for that matter, would you go straight to Coumadin, or do you use aspirin or Plavix first?
We would start conservatively, obviously. We tend to have aspirin first, of course, because it's relative safety. Quite a few patients don't like aspirin, and we would use clopidogrel, Plavix, as an alternative on a look-and-see basis. Having said that, which is, I guess what you're saying, is that then what about patients who don't respond? It's a huge jump, isn't it, from aspirin to Coumadin, and we're scared of it, teenagers are scared of it. So what we do, which is very much our own little thing, is we try 2 weeks of low molecular weight heparin. Not old-fashioned heparin, but low molecular weight, clean heparin, non-toxic. We use it in pregnancy for 9 months without problems. And we give the patients, especially if they're good observers and so on, heparin injection for 2 weeks. And they come back and they say, how are you? And it's either useless or it's fantastic. You get a very clear cut. And I think we then, in those difficult patients, move on to Coumadin.